conference, the 13th Bورسعيد Neonatology Society Conference. I wish to be there with you today, to be in my homeland, Bورسعيد, but unfortunately, due to the obligation at work, it is not possible. So I will go to the slides immediately because of the time. Today I'll be speaking about the topic of the golden hour, and I wish it was this golden hour, the Rolex golden hour, but today I will take you into a different way. It is the golden hour to stabilize those extreme preterm babies to our in the neonatal intensive care unit. I have nothing to disclose. Today I will not be speaking about the neonatal resuscitation program, not about the stable program or the unit-specific practice or protocols. I'll be speaking about the golden hour, and the idea behind the golden hour came from the term that was representing the urgent need for care after trauma in the accidents, and it implies that morbidity and mortality are affected by the care given to those cadavers within the hour of the injury, and how come the outcome was improved if the management was done during this 1 hour. So can this be implemented to neonatal intensive care or no? This will what we will discuss, but we should know that the person behind this golden hour is the Dr. Donald Trunke, who has summarized the golden hour into the 3 R's, the getting the right patient into the right place in the right time. So what is the golden hour in relation to the neonatal intensive care units? It is the time period during which the newborn faces the challenge between the intrauterine life to the extrauterine stabilization and changes that will happen whether at the circulatory level or hemodynamics levels or thermoregulation level. And the decision taking during this time is based on the multiple system that requires attention, and this is what we are going to discuss during the next 20 minutes. So it was started in 1999, applying that the term to facilitate the transition to extrauterine life, and now it is recognized as the golden hour in extreme low birth weight infants. And why we are interested in the golden hour? Because we should know that around 12 million births per year is recorded, and it is estimated that 1 million of them will die as a result of complication from prematurity. In the United States, it is the second leading cause of the death among the infants. And preterm are often exposed to the open environment during the admission process and can rapidly lose the body heat if the proper thermoregulation is not practiced. And the protocols and the guidelines, which vary from institution to institution, which will provide a systematic approach for the delivery room management. And this is will differ, as we mentioned, between the different units, and the guidelines or protocols should be tailored according to the unit specification and unit setup. So you will never find a golden hour guidelines that will fit all the units, but we should tailor our guidelines or protocol based on our setup. We should know that most, but not all infants will adapt to the extrauterine life, and hence 10% will respond to the change in the environment, and they can respond to the drying, the stimulation, while 85% will not need even resuscitation or intervention. And only 5% of those deliveries will need positive pressure ventilation, and 0.4 to 2% will need the intubation. So what are the components of the various components of the golden hour or the golden 60 minutes? And we will hear about during those 60 minutes, we will be having the platinum 1 minute. So we're having 60 minutes, which is the golden, and this is the stabilization from the time of birth till the first hour of age. And the first minute of this golden 60 minutes is called the platinum minute, where we want to make sure that the cardiorespiratory function is stabilized during this minute. So what are the components of this 60 minutes? We are having the antenatal counseling and team briefing, and the idea behind the golden hour is mainly depending on the team work, and not only this, and the proper communication. And you will come to know and you will be astonished that many of the morbidities that happened for preterm babies in stabilization are due to lack of proper communication. Then comes the delayed cord clamping, prevention of the hypo and hyperthermia, support respiratory system, cardiovascular system, early nutrition, prevention of electrolyte disturbance, initiation of breastfeeding, infection prevention, and starting of the first dose of antibiotic, and laboratory investigation, monitoring records, and communication with the family. Imagine all these points should be conducted during the first 1 hour after birth for all our preterm newborn. As you can see here, this is the steps that we should do for each preterm baby for stabilization during the first hour. And as I told you, it differs. The steps will differ from one unit to the other. So it is not this that will be implemented in the all. The steps are, yes, to be implemented, but it should be implemented based on the priority of the unit itself. But we are having some strategies and some important points that we should keep in consideration. And most important of it, as we mentioned, it is the communication and collaboration, whether in the inter or intra team members, using the evidence-based protocols and procedures. Also to standardize as many elements as possible for delivery and initial management of preterm babies. And we should not forget the good communication with our colleague, the obstetrician, about impending preterm birth and taking the proper history from them. Again, the collaboration and counseling of the parents, this is a very important point in the strategy of the golden hour. Another important point, which is the pre-resuscitation checklist. Each unit should have a checklist for which the neonatologist or the nurse in charge should check before the delivery of any preterm babies about the availability of all the equipments needed in order not to miss any equipment, which can delay the process of the golden hour. The team leader has an important role in assigning the responsibility of the personnel attending the preterm delivery. Stabilization of the airway and cardiopulmonary support is very important, and it will help maintaining the vital signs and paying attention to multiple aspects of the patient condition, such as the vital signs, saturation, response to resuscitation, and maintaining the temperature. Keeping in consideration while resuscitating the baby, we should prevent the injuries like the lung injury and use of the high oxygen concentration, We should also concentrate on the initiation of the vascular access, and if the baby needs therapeutic intervention like the surfactant or the volume for resuscitation. These are the multidisciplinary team members that are required to attend any preterm delivery, and it includes the neonatal team, midwives, obstetrician, operating theater staff, and practice educator. All this should have a role in the multidisciplinary team management of extreme preterm baby. The problem of resuscitation, we know that the extreme preterm baby are having the possibility or the tendency for many problems, such as hypothermia, such as delayed in the vascular access, or such as delay in the ventilation itself, or the baby is not breathing, so he will need proper resuscitation and ventilation. All this requires multiple caregivers, as was discussed earlier. And the condition here that we need a teamwork, working not only on the evidence-based treatment, but also as a team structure with a proper communication and proficiency in order to give the better result, rather than attacking each other, such as in the background pictures. So this is in the background picture, it is a team, but they are not working as a team, they are working as two different teams. The critically ill infants are among the most fragile patients, and they are having the possibility for errors. And as I told you earlier, that the Joint Commission investigated cases of infant deaths and injury during the delivery, and it was proved that it is due to the communication error between the team members. So what are the problems that the periviable neonate or the preterm babies might be prone for? Most important is the hypothermia. They are having a very high incidence for the hypothermia. They are having poor energy stores. They are having immature tissue that are damaged easily by the hyperoxia, and immature nervous system that may lead to a poor respiratory drive, weak chest muscles that will lead to limitation of the adequate ventilation, surfactant deficiency. They are prone for increased risk of infection, and they are having fragile capillaries that might lead to rupture of the capillaries in the brain and lead to IVH. They are having a small total blood volume, and that's why they are more susceptible to hypovolemic effect of the blood loss. So whether you are using the 8th edition of the neonatal resuscitation program, or whether you are using the European Council resuscitation guidelines, we should insist on one of them based on your practice. We should have staff attending the delivery according to the local guidelines of your hospital, and those personnel are having the proficiency in dealing as a team members and team leaders who will delegate the responsibility of the care to the newborn babies. We recommend, if the baby is term and healthy, to be attended by the midwife, but if the baby is low birth weight or extreme preterm babies, at least we should have 2 to 3 personnel according to the latest recommendation of the 8th edition of NRP, and optimal scheduling if possible. And what we mean by the optimal scheduling, if we are having a preterm delivery and we can postpone it then it is better done in the morning with the availability of the maximum staff in the unit, rather than having it at the midnight where we don't have the full staffing of the unit. We should do a briefing and clarifying the role, and this is the communication issue that we spoke about earlier. Training our doctors and nurses about the resuscitation guidelines that we will use, and we can make it as a regular practice, making frequent mock drills for our team and the team and leadership training, and giving a simulation-based training whenever possible. So the steps are mainly depending on those 5 steps: is the delivery room temperature stabilization, delayed cord clamping, the delivery room respiratory support, delivery room oxygen use, and the cardiac compression and medication that should be used. I will be tackling each of those points fast during the next few slides. Why we are concentrating on thermal regulation? As we know that the thermal regulation is controlled by the hypothalamus, and the hypothalamus is, whenever it is stimulated, it will stimulate the norepinephrine release, and this will affect the pulmonary and the peripheral vasculature and stimulate the glycolysis. Normally the glycolysis occur through the aerobic process, but in extreme low birth weight infant, it will convert the glycogen to glucose via the anaerobic process when the infant is stressed. So we should take care of this point. The infant regulation, or the temperature regulation in extreme low birth weight, we mentioned that the baby is having large surface area, large body surface area, with limited development of the epidermal layers of the skin and the superficial vasculature, and hence they are prone for the hypothermia rather than as compared to the term babies. Also because they are passing through a stress procedure, which is the delivery at the preterm age, they are prone for the anaerobic metabolism, which will consume the glycogen and the brown fat stores, increasing the metabolic demand of the brain, heart, and adrenals, which will put the baby more under tension. For this, hypothermia can lead to many consequences, such as the increasing in the oxygen consumption, difficult in resuscitation or prolongation of the resuscitation process, abnormal coagulation of the baby, coagulation profile, post-delivery acidosis, delayed adjustment from the fetal to the newborn circulation, increased risk for the respiratory distress syndrome, necrotizing enterocolitis, and the IVH. We mentioned about the checklist. Each unit should have a checklist on what are the equipments that should be ready before the delivery of extreme preterm babies, and you can get those checklists from online, and please tailor it according to your setup. And it differs between those babies who are more than 32 weeks and those who are less than 32 weeks, because each category are having different risk factors. For those who are more than the 32 weeks, we should protect the infant from the changes in the circulation or the circulation of the air, ensure that all the windows and the AC are appropriately programmed, and keeping the environment temperature between 23 to 25 degrees centigrade. Dry the infant immediately, covering the head and the body apart from the face. If no resuscitation is required, then I will put immediately the baby to the skin of the moms and cover both with the towel to initiate the connection between the mother and the baby. And the ongoing careful observation of the mother and infant will be required if the baby are more preterm and are gross restricted. If the baby needs the support, then we will take the baby to the preheated radiant warmer, and we will continue our resuscitation. For those who are less than 32 weeks, we need more equipments and availability of the respiratory therapist and the nurse to help the doctor. And we need also other equipment such as the monitor, the pulse oximeter, or the cardiac monitor. And we need all the equipment that is needed for resuscitation. All this, if the checklist is available, it will help a better outcome, and it will facilitate the task of all the team members. Also, we need a polyethylene wrapping, and we'll put the baby immediately in this wrapping without drying. And this is a very important point and should be kept in consideration, that all extreme preterm babies less than 32 weeks, we will put the baby without drying into those polyethylene wrapping and put the hat over the head immediately. And here comes the point of increasing the room temperature to more than 25 degrees, which is not convenient to the obstetrician, but we should insist as neonatologist whenever we are attending a baby or less than 32 weeks to have the room temperature more than the 25 degrees centigrade. We are having the preheated blanket and the head cap thermal mattress, and make sure that those infant is receiving the respiratory support with the warmed, humidified respiratory gas should be considered. While we are resuscitating those who are less than 32 weeks, we should place the baby fully under this resuscitator or under the resuscitator, and preventing the draft or the draft of air with flat resuscitation. And there may be different step up based on the classification of the hospital or local boundaries condition. We should preheat the mattress and keep the radiant warmer on the recommended level, which is reaching between 80% in most of the cases. Whether we are using the European Resuscitation Council or the American Heart Association, we should follow one of them. Also, we should keep in consideration that the preterm babies are more prone for loss of the heat through the 4 steps of or 4 ways and methods of heat loss, like the conduction, convection, evaporation, and radiation. Hypothermia is common in extreme low birth weight, as the data provided by the Epicure, Vermont Oxford Network, and the neonatal research networks. We are having the data telling us that up to 30% cases of between 24 to 25 will have admission temperature less than 35 degrees, and this can affect the short and long-term effect on the babies after birth. So it is a common, it is seen in all the units, or the most of the units who are not having this golden hour guidelines. And it has this hypothermia is harmful because it is associated with increased risk of mortality, IVH, pulmonary insufficiency, hypoglycemia, acidosis, and late onset sepsis, which is increased by 11% for per each 1 degree centigrade decrease in the temperature. So how we can prevent this hypothermia? By increasing the temperature in the delivery room, by using the servo-controlled radiant warmer, by drying the baby if he's more than 32 weeks, or putting the baby under the polyethylene wrap if he is less than the 32 weeker. But we must also avoid the hyperthermia, because it is as dangerous and harmful to the baby as the hypothermia. We can use the warming mattress and woolen or polyethylene plastic wrap and transport in enclosed isolate. Again, keep in consideration that hyperthermia is also dangerous. The second point, which is important, it is the delayed cord clamping. And when we use the delayed cord clamping, we should implement it in the proper way. You can see here that the level of the baby and the cord is lower than the level of the placenta to allow the blood flow from the mother to the baby. And by this, we can ensure that the delayed cord clamping did its effect that we needed, which is getting the benefit of the blood in the cord to reach the baby, because it is a sort of importance for that baby that will prevent complication later on. The evidence behind that is that the umbilical cord belongs to the baby not only before the birth, but also immediately after the birth. And the content in this umbilical cord is related to the baby rather than the mother. The baby is not to be depleted of this blood, which will help the circulation to the lung after the birth. And the question, how optimal the time to clamp the umbilical cord after delivery, is still controversial. It is based on the latest its NRP. It is between 30 to 60 seconds after the birth, based on the condition of the baby. The more the stable the baby, the more the length of the delayed cord clamping. And this will usually allow a transfusion of 60 to 200 ml of blood into the infant, which is equal to 1 or 2 blood transfusion for an adult. The systematic review trial suggests that for otherwise uncomplicated preterm, we can delay the cord clamping between 30 to 160 seconds. Some of the studies now are showing that we can delay up to 6 minutes even, but we don't encourage to go for that whole timing. It is still under study. All this will improve the blood pressure, will decrease the incidence of the IVH, and decrease need for blood transfusion. Although some of the studies are telling it will increase the incidence of neonatal jaundice, but limited data is regarding to this. Also, we should not use the delayed cord clamping as such between 30 to 180 seconds if the baby is not vigorous or he is not breathing. So we should see the baby's condition first and decide about the delayed cord clamping. Number 3 is the delivery room respiratory support. And we encourage here using the non-invasive respiratory support based on the latest recommendation of the NRP. We should know that the neonatal lung function change immediately upon delivery from the intrauterine ventilation to the extrauterine ventilation or the extrauterine hemodynamics and circulation. And the very low birth weight is impaired with this transition because the immature structure of the heart, of the lung and the chest wall, the delivery room practice are contributing to the long-term effect and development of the chronic lung disease if I'm causing a lung injury. That can happen with the first few breaths after birth. What is our respiratory management? The lung tissue function can be altered within the first few breaths based on delivery room management. Surfactant, we know that those babies are prone for surfactant deficiency, so our surfactant should be available and ready, and it is encouraged to be given in the delivery room unless that the neonatal intensive care is near to the operating theater or the delivery room. Therefore, respiratory support methods are needed. Efficient workflow should be done. We will be hearing in the near future about the standardized resuscitation protocol where they are using the 12 o'clock settings, where you will have all your settings set at 12 o'clock. This is the pressure of 20 at 12 o'clock. You will find that the oxygen 100% is at 12 o'clock. You will find that the PEEP also, it will be at 5 at 12 o'clock. All the settings will be at 12 o'clock. So whenever we see our resuscitator and we'll see the 12 o'clock, that means we are ready for resuscitating the preterm babies. The CPAP intubation and surfactant in the prophylaxis surfactant will be followed by a period of mechanical ventilation. The Ensure is again used in most of the units where it will help opening and recruiting the alveoli, giving the surfactant, giving the volume, and then extubate to the bubble CPAP, and giving a continuous CPAP with the bubble methods, like in the Colombia practice with Professor Hani Ali and Dr. Wong. The outcome and deaths and chronic lung disease, there is no difference between the different methods, but the group of the nasal CPAP are having better outcome where they are having less intubation and less babies without the surfactant. Then we are having the neopuff in the delivery room. This is what we recommend, using the neopuff rather than the ambo bag, because it will give a consistent pressures, and this pressure is preset before resuscitating. So we will be sure we are not giving a higher pressure to the baby rather than using the ambo bag, which will give a non-consistent pressure, and sometimes I can give a higher pressure that can cause a lung injury. So using the neopuff will give a consistent, easy to use, manually operated, and it will give the pressure required to open the alveoli. Keeping in mind that giving a higher pressure with ambo bag can lead to a lung injury, like the picture on the extreme right side, like giving 20 minutes of high pressure can cause the lung injury. Coming to the delivery room oxygen use, we are having two policies. For those who are less than 32 weekers, we should provide the pulse oximeter immediately to the baby, and using the resuscitation oxygen between 21 and 30%, and titrate according to the saturation on the saturation monitor. Why we are using this? Because the hypoxia hyperoxia effect can lead to critical events or consequences, such as the oxygen toxicity syndrome, due to release of the oxygen radicals that can cause morbidities like ROP, BPD, IVH, and necrotizing enterocolitis, and can lead to hepatic necrosis and can keep the ductus open as well. Blended oxygen is advocated for the neonatal resuscitation, and as I told, a pulse oximeter must be available for those preterm babies. For the term babies, we can use the room air, which is 21% of oxygen. This we discussed in the previous slide. Oxidative stress result in the free radicals that will cause the oxygen toxicity syndrome. we should measure the oxygen in the preductal saturation in the right upper hand or arm, and we should monitor the baby on the oxygen monitor or the pulse oximeter and titrate our oxygen based on the oxygen saturation. Another important point in the saturation that we should attach the monitor to the sensor to the baby, and we should follow the staging of the oxygen saturation, and we can keep the oxygen, we can keep the physiology to take its process, keeping in mind that intrauterine oxygen saturation is ranging between 25 to 35 millimeter mercury. So we can accept the delay in the increasing in the oxygen saturation and reaching the level of 85 to 95 by 10 minutes of age. This is the latest recommendation starting from the 7th edition of the NRP, and this as it is available in this slide. Last but not least, we should concentrate on the chest compression and what is the strategy and medication behind the compression and the medication based on the NRP. And if the baby is having a respiratory rate, heart rate less than 60, a chest compression is indicated, and the extreme low birth weight who receive chest compression medication in the delivery room and have 15-minute Apgar less than 2, having only 14% chance of free disability survival, which is we should keep in consideration that it is one of the crucial points that will help the outcome for those extreme preterm babies. We should also give the fluids to maintain the hypoglycemia and prevent any electrolyte disturbance, to prevent the hypotension by giving the immediate fluid after the birth. And also we should give the to treat the hypotension, but we should keep in consideration that giving the fluids, the bolus fluid, might cause increase in the rapid flushing, can increase the rate of IVH for those babies. Inotrope to maintain the blood pressure is very important, and we should also concentrate on the administrating the antibiotics in the first hours and of after birth, and how to implement this. We should have critical clinical practice guidelines. Not only the guidelines, we should have an audit on a regular basis on whether we are implementing those points in the guidelines to prevent all the consequences of the extreme preterm baby. And don't forget that achieving the golden hour is the result of a team approach from all the personnel. And by this, I will finish my slides, and thank you very much.